Hello and welcome to today's webinar, Rethinking HEDIS and Value-Based Care to Optimize STAR's Performance. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available within 24 hours. If you have any trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Michael Curran and Randy Streit. Both come with more than 20 years of healthcare industry experience. Michael is the Vice President of Product Management at HEDIS with expertise in the areas of quality improvement, risk management, data operations, and data analytics. Prior to joining HEDIS, he served in leadership roles at Harvard Pilgrim Healthcare, UHG, and Aetna. Randy is the Senior Director of Consulting for Government Programs at HEDIS Tech, and with proficiencies in the area of quality STARS, risk adjustment, population health, and financial performance. Previously, he worked for leading health plans, including Capital Blue Cross, Coventry Healthcare, and Universal American. At this time, I'd like to turn the floor over to Mike.
Thanks for that introduction and welcome again to our continuing webinar series. As mentioned, we will be discussing how we measure performance and what measures should receive more emphasis as we move into an era of changing STARS and the growth of value-based care. The focus is more about rethinking measurement in general rather than HEDIS specifically, though as we will discuss, new areas of focus include numerous metrics already tracked through HEDIS. We will start with a review of how reimbursement trends have changed over the last couple of decades and how these changes have directly impacted the evolution of quality, efficiency, and ultimately value measurement. We then will take a deeper dive into how in today's world of CMS STARS and value-based care, how it's creating a new dynamic and how that will in turn impact what we measure, how we measure, data needs, and program structure. To begin with today, we thought it might be helpful to frame the challenges of today with a look at how the payer-provider relationship has evolved with respect to reimbursement and how those changes have in large part determined the measurement agenda. Phase one, we are calling the participation phase. During this phase, reimbursement is, for the most part, fee-for-service to providers. As managed care increasingly takes root, there was increased pressure of cost management from payers to the provider network in the form of medical appropriateness guidelines that would govern what was paid for and what was not. The financial temptation in this dynamic was for payers to be too restrictive in payment to save money. An oversimplification probably, but this type of concern gave impetus for organizations such as NCQA to enter the scene to help ensure that managed care was carrying out its promise of higher quality at lower costs. Accreditation programs now evaluated health plans on the structures in place for monitoring and managing utilization, for assuring quality, and for having processes and opportunities for members to appeal and fully understand decisions impacting their care. The logical extension of ensuring the plans were keeping the oath of higher quality at lower cost was that a measurement component needed to be put in place to ensure reliable and comparable assessment of quality, use of services, and member satisfaction. This measurement agenda, as you might expect, was focused on the payers almost exclusively. If a payer organization wanted to participate in Medicare Advantage, or if they wanted to compete in markets with direct accredited competition, payers would need to be accredited primarily by NCQA as a requirement would need to publicly report on performance data, HEDIS and CAHPS obviously being the most predominant. So in this participation, demand-based environment, what did measurement look like and how was it used? Measures for the most part looked at how well managed care plans were accomplishing the quality cost mission. So on the quality side, we saw measures focusing on preventive care, breast cancer screening, cervical cancer screening, flu shots, also focused on high incidence chronic conditions such as diabetes, asthma, high blood pressure, and then of course, utilization of service. Capturing results and publicly reporting was of primary importance because it showed a willingness to be transparent, but it only went so far. The act of measuring will influence behavior, and I think that it has been well proven through the years out in numerous studies examining the impact that just publicly reporting alone of HEDIS measures was having on performance of health plans. But the challenge was now was really to how to drive true additional improvement across the system. So this brings us to what we're calling the performance phase. During this phase, measures themselves did not change greatly, but how they were used to drive improvement, performance improvement began to change. During this phase, a financial reward element was added, which is where we are now. But as we will discuss is in a few minutes is quickly changing. Pressure on the payers from CMS increases as reporting alone was not enough anymore. Improvement needs to be demonstrated on dimensions of preventive care, management of chronic conditions, member satisfaction, and overall plan ratings for Medicare Advantage plans for both Parts C and D. The pay for performance era really began to take hold as CMS star ratings created new incentives for payers by linking financial bonuses and advantageous marketing and enrollment opportunities to those plans that could measurably demonstrate superior performance, whilst at the same time creating heavy penalties for plans that could not demonstrate improvement. This phase also marks a move from a measurement environment that focused on payer performance exclusively to one that increasingly focuses on providers and delivery systems and the impact incenting them to participate in measurement programs that directly relate to stars, related to health plan stars performance. In the performance phase of measurement, we see the emphasis shift away from more transactional measures of utilization to measures of member satisfaction and more of coordination of care, where we see transitions of care measures, medication reconciliation measures, as well as the traditional preventive and chronic care measures. The performance era when it comes to the payer-provider measurement relationship is largely marked by retrospective reporting from payers to providers in a one-way information flow that lacks robust opportunities for provider feedback. As we move into this next phase that we are calling partnership, it is clear that the reactive and often incomplete picture of quality, of cost, and quality will not suffice. The partnership measurement phase aligns to the rapid growth and deployment of value-based care programs. While participation in performance phases of measurement focused on engaging payers and providers, success in the partnership model when it comes to stars and value-based care requires a laser focus on engaging the member. Value-based programs with downside risk or shared savings with shared savings arrangements apply pressure to the provider network to focus on minimizing costly inpatient events while improving overall health outcomes. This can only be done by engaging patients effectively. So to provide more insight into this partnership dynamic and how it impacts what, and more importantly, how we measure quality, cost, and overall value, I'd like to turn it over to my colleague, Randy Streit. Randy.
Thanks, Mike, and good morning to our audience, and thank you again for joining us today. As we work through the changing environment Medicare Advantage continues to present, being able to adapt to the needs of the membership and reimbursement models aid in the sustainability and competitiveness of health plans. As Mike commented, the relationships among the stakeholders has migrated toward interdependencies where partnership is critical to success. Consumer behavior is also changing in the Medicare space as individuals are aging in with buying experience and bringing normal consumer behavior and expectations with them, changing their interactions with providers and payers. Coupling consumer behavior with star rating model changes through the increased weighting of member experience measures and Tukey outlier deletion, health plan approach to maintaining and improving star ratings needs to, and likely has already begun to shift away from the traditional process measures. Process measures still have an influence on the ratings and cannot be ignored. but with a higher influence of the member experience measures, utilization, outcome-based measures, and administrative measures, plan, provider, patient coordination, and alignment is critical. While the increased weighting of member experience measures has been well known in the STAR space, it may have hit home with the release of Plan Preview 2 yesterday. Congratulations goes out to those that maintained and/or hit their rating goals. Celebrate, but stay focused on the remainder of calendar year 22. Prepare for calendar year 23 AEP marketing and onboarding members, CY calendar year 23 STAR rating program, and thinking ahead for calendar year 24 benefit strategy. Value-based contracting includes multiple stakeholder accountability in the healthcare ecosystem. This Venn diagram oversimplifies complicated and numerous interactions, but illustrates the main primary and secondary interaction points. Looking at the patients and member stakeholder generalizations, Medicare members are more digitally connected today, fueled mainly by the environment in the last 30 months. Members are not always willing participants in the healthcare delivery system, at times driven by medical events or chronic conditions. Measuring member satisfaction through delayed post-service satisfaction surveys may also introduce new experiences in mind and influence the responses. Members tend to address immediate pain points before engagement in wellness activities, such as socioeconomic issues, managing their own chronic or acute conditions, or even focusing on non-healthcare items that are important, like family, friends, or connections within the community. Members are often balancing being caregivers to aging parents, planning or sometimes delaying their own retirement, and also caring for children or grandchildren. Many external factors are placed well before their own health maintenance. Moving to the payer stakeholder, typically more than one payer is involved with the experience. In addition to physical health, there may be a carrier paying dental or vision or mental health or other ancillary benefits. Each of these interaction points is a potential to influence specific and overall healthcare experience. Most members have the ability to change payers each year. Having the ability to bring medical history to the new carrier allows for quicker program qualification and earlier intervention identification. Payers tend to seek and exchange data to develop information views of members to build initiatives, referred care programs, and for required regulatory submissions. For success in building predictive analytics, data needs to be timely, complete, accurate, as well as secure, a message you will hear throughout this webinar. Finally, we have generalizations of provider stakeholders in the ecosystem. Many disciplines will be impacting member care, primary care as well as specialty care, dental, vision, mental health, in addition to alternative care options that are available today. Some have sophisticated electronic health records that have already identified process quality measure needs, such as preventative services or scheduled lab testing. Members tend to have long and trusted relationships with specific providers, whether it be a doctor, a nurse, or a pharmacist, and value and protect those relationships. Staff deeply care about the health of their members, adapting to changing environments. We've seen this with brick and mortar offices providing virtual care directly or as an option. The intersection of these stakeholder interactions illustrate the interdependencies. Looking at the provider-patient intersection, this includes traditional care delivery of medical, dental, vision, pharmacy, mental health, in addition to non-traditional healthcare. Patients may be subjected to marketing new service options such as locations or buildings, more virtual or even delivery disruptors. Engaging with community resources to address the social determinants of health, such as food needs and transportation needs. Interoperability across provider space is assisting in more managed care coordination, which is a CAHPS-based measure in the storage rating model. Providers are also the primary source for reminders, whether that be for appointments, preventive scheduling, as well as prescription refills. Shifting focus to the patient-payer intersection, traditional relationship between patients and payers is transactional, as well, with patients, members, or consumers purchasing benefit packages directly or through their employer plan. Members want and expect a low burden in using benefits. While the No Surprises Acts helped, having predictable costs and avoiding claim reprocessing for systematic issues, such as incorrect benefits, onerous payment policies, or untimely loading of contract terms, can prevent negative experiences. Population health, case management, and disease management programs provide health literacy improvement opportunities, but are dependent on reaching the right population at the right time through the preferred media. However, increased knowledge does not necessarily lead to improved health. The major barrier with behavior change is overcoming customs or years of habit forming. Member experiences often start with marketing messaging. As we are about 5 weeks away from the start of AEP, ensuring communication channels are aligned with what members can and should expect at the start of their enrollment period can reduce the friction members may feel when their expectations are misaligned due to the selling and/or onboarding process. Finally, the provider-payer intersection. As Mike led off, the participation phase of You Do It, We Pay It claim processing is primarily a financial transaction with contracting and reimbursement rates within the network or allowance out of network. Payers should work towards minimizing noise through adding to the knowledge base. Redundant or obvious messaging may desensitize the audience to relevant or desired messaging. Plans should be cognizant of lowering policy administration burdens as well that distract provider focus and attention away from delivering care to the patients. Understanding providers that have many payers giving specific direction or policies may influence interactions with all payers. Integral to population need identification and service referrals is data exchange. Again, with the accurate, timely, complete, and secure data sharing, this allows payers to feed predictive analytic engines and providers to understand metrics outside of the practice delivery impacts. Payers accumulating and aggregating healthcare data and consumer data can populate predictive analytic engines to identify situations, diagnoses, environmental, and care needs. The ability to track and predict well is dependent on accuracy, completeness, and timeliness of the data feeding the engine. Investing in population health and initiatives in communities may assist in reducing or removing barriers to healthcare, either through balancing the health equity needs, removing care stigmas, or even removing negative environmental impacts on health. The intersection of all three stakeholders is aligned messaging, aligned incentives, and shared goals. This is the application of initiatives and realization of coordination across the stakeholders. Success drivers live at these intersections. To monitor and review progress towards goal, indicators feeding various indices allow plans to evaluate and correct as desired. As the incentive and reimbursement models shift from transactional or process measure focus, aligning incentives through value-based contracting need to shift as well. The incentive models may migrate from fee-for-service gap closure incentives to performance against external benchmarking. Star cut points provide a consistent measuring stick to evaluate health plan performance. Transferring health plan rating model to provider performance aligns these goals. Quality measure components of the value-based contracting also shift from being a gatekeeper to shared savings to a scaled percentage applied to the reconciliation period. To assist in identifying meaningful and impactful populations, health plans and providers can create indices through various indicators to understand member needs and plan interventions. Examples of some indices that could feed predictive analytics are noted on this slide. Please note that these four are not the only indices that can be created. You may have your own. Care Coordination Index addresses members with chronic conditions and/or fragmented care patterns, members that use the healthcare system inefficiently or have uncontrolled disease states. This index may help address needs and positively influence the CAHPS-based care coordination measure through identification of members that may experience less than desired coordination with their care delivery. Interventions include identifying and using medical homes, coordinating care across the ecosystem, along with the data exchange. Approaching the imperative message of complete, timely, and accurate and secure data exchange to feed the predictive analytics engine. Many times, new membership health needs or changes in continuing member health status are noted when a claim or service is rendered. Periodic health assessment data capture and insights can identify members sooner for appropriate intervention. The thought here is the claim is too late to find out. And some of the measures that we do have a delivery care window, the claim lag may delay notice of the event outside of that intervention window and no longer have the ability to impact that measure. Along that line, follow-up care for emergency room, inpatient discharges, or testing both positive and negative results can be referred out or confirmed through consistent data conversations across the ecosystem. This will influence several quality measures in the rating model. Another indicator for the Care Coordination Index is the prevalence of fragmented care. With members seeking care at multiple providers, the opportunity for care coordination issues increase. Understanding provider thresholds allow identification and predicting the levels of fragmentation in care delivery. The Care Coordination Index works towards wellness mindset and preventive service delivery. The administrative index may be the easiest but most challenging to address, as you may be working with internal but separate business functions operating within other goals. I say easiest, but I mean areas and interventions you may have the most influence or control. There are two CAHPS measures regarding member waiting times: getting needed care and getting needed care quickly. These are highly subjective, but having open and transparent conversations with expectations over scheduling and on-site wait times can positively influence and ease member expectations. A hidden wait time in the experience is the claim lag, the time between date of service to receiving the explanation of benefits and knowing the payment liability. Reducing or eliminating this time delay condenses the experience in a shorter window. Understanding claim reprocessing rates and reasons for claims needing reprocessing can lead to initiatives to reducing or avoiding reprocessing altogether. Members needing to call in monthly because their claim continues to deny for claim processing rules is an easy way to receive lower satisfaction scores across many survey questions. This underlying nuisance may ensure a response and skew those responses. Including clinical data information exchanged by member builds an indicator for testing completeness to building the holistic view of the member. Having post-visit, post-call survey responses allow parties to quickly identify potential pain points for other users of the ecosystem. Similar to the post-service surveys, continuous review of complaints and/or call center topics can uncover unexpected points for abrasion as well. These scenarios can be evaluated for additional exposure. Firming up marketing messages and training practices ensure the interpretation of benefits by the member is as intended and well-informed enrollment is finally made. Adding new and different supplemental benefits may require additional communication with members to understand coverage and how the benefit could be used. Performance indexing uses utilization metrics and financial metrics to inform performance of segments. Comparing allowed cost to revenue provides a true cost compared to actual spend that may show savings through benefit design changes or cost shifting. Providers documenting social needs and submitting through Z-codes allow health plans to review needs and create initiative programs to address the barriers to wellness. Comprehensive medication reviews can identify polypharmacy needs for medication reconciliation or adjustments. Coordinating and confirming medication, dosaging, and adherence allows plans and providers to identify potential needs for changes or other assistance. Appropriate emergency room and inpatient admission utilization metrics are pretty standard these days, and most incorporate external benchmarks for these utilization metrics. Provider and health plan screenings for mental health issues and referring for follow-up care can be appropriate for all lines of business. We all hear news and the impact of isolation has had on the population recently. Keeping members connected to the family, to the community, and themselves through mindfulness may prevent health deterioration. From a pure technical view, evaluating and submitting appropriate documentation for accurate and complete risk adjustment factors and ESRD flags shortening the true-up cash flow well after the contractual experience period ends. Measuring and evaluating substantiating conditions, retrospective reviews, and coding accuracy allows plans and providers to focus on current care delivery. Now, applying the Plan, Do, Study, Act quality cycle to an intervention index allows plans to understand response, outcomes, and effectiveness. These indicators highlight what is working well with throughput metrics, but also can highlight where resources may need reallocated. Typically, these are found in outreach campaigns, health education, appointment settings, and additional care options. As you may have noticed, HEDIS and PQA and other measure stewards have an influence throughout these indices. The intent is to incorporate and continuously monitor the measures included in the regulatory filings and identify needs and initiatives throughout the contract year. The indicators should uncover unmet needs or lack of response to current initiatives through continuous monitoring. Software monitoring or using dashboards should be flexible enough to adjust underlying population for segmenting or cohort studies. Creating these indices or having your own indices relies on potentially disparate or different data sources than traditional medical claims, pharmacy claims, member demographics, and enrollment feeds. This slide illustrates potential data sources to feed indicators. Similar to the indices slide, this view should be ever evolving to capture new and potential data feeds that have an impact or influence on a member's health status. Your data roadmap should capture current feeds within the enterprise, not only those limited by specific reporting or function usage. In the interest of time, I'll quickly highlight just a few of these sources. Some of these have been referenced earlier in the presentation. Looking at benefit design, understanding your current benefit design as well as changes over time, can lead to explaining member utilization changes. Careful attention should be given to care avoided compared to care delayed. Are benefits aligned with your community messaging, and are they affordable and relevant to your population? Completing health risk assessments for new membership and renewing membership can provide insight into their view of current health status, social needs, and evaluate level of health literacy and engagement. It is important to use these data timely to remain relevant and build trust. And finally, pointing out clinical labs. Beyond the usage of lab values for regulatory reporting, plans may be able to identify trends with clinical values and use for qualification or referrals for specific programs. Sharing results with providers can also facilitate service delivery before a condition becomes uncontrolled. Data from wearables would also fall into this category. These may be leading into insights into sleep and activity patterns as well. This honeycomb may look different for your plan and your current needs. Consistently reviewing the data acquisition picture and reviewing the enterprise inventory helps understand the current needs, as well as highlighting opportunities for additional inputs and interventions. I'm now turning the presentation back to Mike to talk a bit more on the importance of payer organization and infrastructure to drive success today and remain flexible for future changes moving from data acquisition to insight application. Mike?
Thanks, Randy. That was great. So I think the last major point I think we would like to make here today is that as we've hopefully shown, the way we measure, share data, and collaborate is an ever-changing experience. What we measure and how we measure and use data is important, but so is the question of how we structure for success in this fast-changing environment. If there's one certainty, it's that all payers and providers will be at different maturity levels when it comes to effectively measuring and executing improvement on STARS measures and securing the rewards that come with great outcomes from value-based care programs. During our discussion today, I think we've taken a fairly balanced view of the partnership between payer, provider, and patient that needs to be present going forward in this partnership era. But for the next few minutes, I'm going to focus more on the challenges payers specifically face when creating the infrastructures to drive success. So as I try to show here in this image, oftentimes what you will find in a payer organization is multiple very well-intentioned teams within an organization managing various and similar programs across the organization. You could have a value-based care program running out of your network management part of your organization or finance part of your organization, relying on claims and encounter data, and using different a different set of attribution logic than the quality team or the regulatory program team that is running gap closure programs for HEDIS and STARS, who may also be pulling different data and using different inclusion criteria for measures from the pop health team that is also engaging providers um, and around the similar gaps, but using still different data sets. When you do this, you end up with fragmentation where there needs to be alignment and alignment around critical program elements such as data sources, data formats, analytics, and measure definitions. This fragmentation creates, as you get multiple, this fragmentation creates an efficiency as you get multiple outreaches by payers across the provider network, um, and also to members as well, because there has not been effective alignment and prioritization around measured data and action. The impacts of this misalignment are predictably inefficient coordination, incentive programs that annoy rather than inspire, incomplete and actionable data, and then ultimately poor outcomes. The challenge to payers is to strive. The challenge to payers is to strive to create an infrastructure, an organization that is unified and aligned in their approach to outcomes improvement, particularly those related to STARS and value-based care programs. A few areas that we recommend making a careful assessment of program maturity and internal alignment include clinical data interoperability, the importance of two-way rapid communication, and the ability to marry administrative data with clinical practice data is essential to getting the full picture of patient care that builds the kind of trust required in any risk-sharing arrangement. Data curation and governance is also of great importance. Having a mature and adaptable data strategy that is able to curate healthcare data from diverse and changing data sources is essential. This data strategy must be able to address the needs that Randy discussed earlier and render consistent results that fulfill the needs of all programs seeking to improve outcomes and balance that cost-quality equation across an organization. The contract and value-based care management activities should not occur in isolation, but rather seek to have standardized reporting that aligns with other measurement and improvement initiatives within the organization. These programs should also include timely data flow from the provider's clinical practice systems, as I mentioned before, to provide the full view of patient care and adherence to quality measures across the organization. Efficient, centralized management of clinical quality, financial, and operational measures and KPIs to help ensuring the alignment of measurement across objectives, across an organization and coordination of messaging to your provider networks is essential. And then finally, an organizational commitment to regulatory compliance activities, such as HEDIS, SMIPS, ACO, and meaningful use programs that will form the solid foundation for STARS improvement. So, in summation, success in the era of partnership in measurement and improvement really comes down to assessing how well payer organizations and your delivery systems are promoting wellness. We need to acknowledge the interdependencies between payer, provider, and patient in order to create measurement and improvement initiatives that will create the better outcomes for STARS and VBC. And this can be done by re-examining what we are measuring and monitoring in order to create success in balancing the cost-quality equation. I go back to the intersections that Randy talked about. That's where the opportunity for innovation around measure and creating predictive analytics exists. Understand that traditional approaches to retrospective measurement will not get us there, that measurement needs to be predictive in order to anticipate avoidable events that drive cost and suboptimal outcomes, that engages at-risk members earlier through cooperation between payers and providers. This predictive approach relies as heavily on measures of current state as it does on indicators of future state. And that to do this, that payers and providers must work together to build adaptable data strategies and aligned infrastructures that put the patient member at the center of coordinated efforts to promote wellness and fulfill the mission of reduced cost while improving overall results for payer and provider alike. So, so I think it looks like we have a few minutes left to take some questions or even discuss additional perspectives. So let's take a look.
Thank you. At this time, we're going to address some questions, as Michael mentioned, that came in during the presentation. And we might not be able to address all questions in case your questions remain unanswered, or if you have further questions after the program, you can reach out to either Michael or Randy, and their contact details are on the screen now. And our first question is, we have smaller provider groups that do not have large panels. How can we approach value-based contracting?
Mike, I'll take that if you don't mind.
Sure.
So there is a credibility issue with smaller panel sizes, but conceptually, the concept is the same. Focusing on aligning the messages, aligning the incentives, and getting to a place where you're focusing on similar goals. It could lead towards alignment, where the reimbursement or the incentive methodology may not be the same because of the smaller populations. Conceptually, it's the same with quality as a focus, as well as some shared savings if there's any to be had there.
And the next one, it's more of a comment than a question. It said it would be great if this content could be converted to a white paper to be published.
Randy, you can do it.
Mike and I will take that comment back. I appreciate it.
Okay,
Thank you.
Great, thank you. Our next question is, how do you recommend navigating the natural tension between provider reporting and operation preferences and setting up unified and aligned structures for reporting and practice standards?
Yeah, I can take a crack at that. If I understand it correctly, I'm sorry if I'm missing the point of the question. We can come back to it. But one of the things that we've found in conversations that we've had with provider groups that are in the value-based care world heavily is that the ability to have transparency into how everything from the attribution logic, how members are being assigned to their panel, to what the cost basis is for how the PMPM, the cost basis that these risk sharing agreements are set on. So I think a lot of the alignment comes out of building that trust, having transparency into the underlying structures that the structures and methodologies and assumptions that underlie how we set up the measurements. And then the other piece I think that's important is that as you go into these value-based arrangements, know that that you're probably not going to get it right the first, the second, or the third time. So having some room in there to be able to test measurements, make sure that the measurements that you're applying to evaluate these relationships are aligned, that the way your provider groups measure readmission rates is the same as the way the health plan thinks about readmission rates. So I think a lot of that, the transparency and taking the time to test the structures, test the measures, test the data flow, will go a long way to helping navigate that natural tension. And then probably the last piece I would say is that, and I think it's very important, is that the ability to incorporate clinical practice data, clinical practice system, clinical practice information from providers is essential, because a lot of the information historically has been flowing from the payer to the provider, lacks some of that clinical practice information that just shows the fullness of care, and I think kind of gives a better provides better and more accurate results when you're doing things like risk, assessing the risk sharing and the payouts and things of that nature. So I hope that answered the question somewhat, and would happily have a follow-up conversation if there's other things we'd like to explore on that one.
Great, thank you. Our next question is, how do you see acute care hospital providers fitting into the success equals wellness delivery?
Mike, do you want me to try that?
Yeah, sure.
So acute care, all aspects of the healthcare delivery system play a part in value-based contracting, and understanding each each actor's contribution is critical. So to me, acute care hospital providers, um, they play a part with managing chronic conditions, sometimes at the worst aspect of a member's health status. Um, Getting them set up for success after the admission, both post-discharge with medications, assigning or connecting with community resources as needed. That's where I see them plug in. Mike, do you have a different take?
Yeah, a little bit. I think on that, certainly on the what you're talking about there is sort of on the delivery side. I think there's a great data opportunity here too, because I mean, if as we've talked about, the success in these in the based world is really about promoting wellness. And if you have a lot, if you're seeing a lot of acute care events, then you have an indicator. That's a good leading indice that there may be opportunities for you to engage those members that are finding their way there. So mining that data to find out, are there certain disease types, geographical locations, that are that are driving these hospitalizations is a valuable piece of information to share back with the rest of the provider network, and in order to make process changes, and having that data to be able to drill down into will really help drive that. So I mean, being able to have actionable data about what's driving every disease state and what's driving cost is really the way for providers to have control and some power in the relationship around value-based care, and being able to mine the type of data that reflects and I'm not going to say breakdown because it's not necessarily a breakdown, but could indicate a trend of avoidable acute care events, is very valuable. I hope that helps.
That looks like our final question at the moment. Mike and Randy, pass it back to you for concluding remarks.
No, I appreciate the questions, and I appreciate everyone who took the time out today to spend some time with us. I hope this was informative, helpful. I hope it tapped into some thinking around new areas to explore for measurement, a new way to think about and a new way to think about measurement in this partnership era, at those fringes, not at the fringes, but at those intersections, thinking about things more in terms of just indices rather than retrospective measurement, and then again also thinking about how we put structures in place um, to support this kind of change. So thank you. Randy, I don't know if you have any additional comments.
Yeah, we looks like we have one more question that came in um, about CMS star rating for hospitals aligning with CMS star ratings for health plans. That's a great question. I don't think it added anything with multiple rating models having the same labels. So the star ratings for Medicare Advantage, for providers, for ACO, for the ACA world. Um, that's a great question. I think it's more theoretical or than what we may see. What I think what we may see actually is the star quality bonus payment um, being reevaluated, similar to the ACA world, where it's a risk, like a risk pool. Um, that methodology applied to the quality bonus. So I think MedPAC has had a recommendation out there for some time, for a few years, about regionality with quality bonus payments. So it's more of a zero sum game, and I believe it was a Kaiser report coming out recently with Medicare Advantage being roughly 48% of the membership. That's really not likely to be a sustainable model, just adding expense to the system. So we may see shifting soon in the next couple of years with trying to make it more of a zero sum game. I know that didn't directly answer that question. I sort of got off on a tangent, but that is a great question. I'm really not sure how to how to directly address that. Ideally, everything's aligned, but that's not necessarily the case with government agencies.
Great. Well, thank you both. Thank you to our speakers for that great presentation and for sharing your thoughts today. And thank you to our audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.